Let me show you. So we have 2 incentive spirometers here. When I deliver babies and my patient needed a C-section, I'd make sure I give her this before I go, show her how to use it, because the nurses don't ever know how to use it. And so to do these right, you have to inhale, not exhale. Suck the ball. What ball, Shelly? Freak. This ball right here. When you suck the ball, and I do tell that to my patients, unless they're 94 and looking crazy. But some 94-year-olds are freaks, so it's okay. So when you suck the ball, this ball is gonna come up. It's not enough to get it up, you gotta keep it up. That sounded interesting. So you keep it up, and your lungs, what are we doing with this action? We're preventing, hello, atelectasis. Okay, now, before there were gadgets, there were nurses. Be careful. If your tests say what is the best way to prevent atelectasis, and they have the 4 answers that they usually have, which is incentive spirometer, elevate the head of the bed, tell the patient to cough and deep breathe, or give the patient oxygen. Which one is best? Cough and deep breathe, because if you're like my really good friend, a nurse midwife in New Orleans, and Katrina happened to her, and when Katrina happened to her, she was literally in the operating room finishing up a C-section, sort of like I do here by popping in the staples. So she's just closing the patient up, and the water is quickly rising up her legs. When this patient is finished getting her last staple in, they are literally lifting this patient up and over into the helicopter. That patient has just had major abdominal surgery. They are at risk, like all other post-op patients, for pneumonia based on atelectasis. So last time I checked, my friend is not the type to go around looking for a little gadget. But when that patient went in that helicopter and was received by the nurses and doctors in that helicopter, you best believe that nurse was teaching that patient how to cough and deep breathe, because there were gadgets, true, but before there's gadgets, there's you and me. And that's why you have to know the basic way to do everything. You cannot say, oh, we have chest physiotherapy vests at our job. We don't have to do all that. We just put the vest on and it vibrates and everything. Okay, you try that shit on a test. Ain't gonna work. So what you see here, when you look here, you see you start within 1 hour after surgery for that incentive spirometer. And you do that shit 10 times and you're sitting up while you do it. All that shit on the test. You follow each session with a cough. That's the last line. You see the high followers and follow each session with a cough. You see I even wrote the big $4 word, atelectasis. You see it all in there, right? Okay, so that's important. Everything I say it again in writing. Okay, now I want you to turn the page and I want you to highlight pursed lip breathing. I want you to highlight O2 therapy. And I want you to highlight CPAP and BiPAP at the bottom.
What do you want us to highlight?
Your pursed lip breathing, your O2 therapy, and your CPAP and BiPAP. So this is the biggest one on the board. This is still under that, okay? This is all still very much under that. Because you know that if your patient has a compromised respiratory system, they may need oxygen, but they may need you to teach them how to use it at home. And if you're doing a home care patient, you better know this list as well. Now, one thing I want to tell you about is the different mask. Look at what it says. The nasal cannula can only go up to 6 liters. Highlight it. No more than 6 liters. Y'all see that?
Yes.
That one is forgotten quite a bit. People just don't remember that. it only delivers a little bit of oxygen. So it's perfect for the intraoperative patient. So when I have a patient and we're doing an endoscopy, when I have a patient and they're getting a C-section, when I have a patient and we're doing an ERCP, we're gonna give them oxygen. It's not that they needed it, it just is really good idea during surgery. You see what I'm saying? But it's not a lot, because if you know room air is 21%. This joker here ain't giving you much more than that. It's say 25 to 40. You see what I'm saying? Now, the simple mask, that's the one in every single hospital room. It's always in there. The simple mask has a little green string and everything. It does not have anything but the mask. Are you feeling me yet? Okay, that's important. And it gives a little bit more, and you can put it all the way up. You see the liters? You can go all the way, 15. Y'all see that? 5 to 15 liters per minute for simple mask. Y'all see? Now this is great for initial respiratory distress until you can get respiratory therapy in the room, or until you can go get a simple non-rebreather. All of this simple mask stuff is great. It is not great long term. And you see that. You can see here with this simple mask, it's poorly tolerated. It smells, it's irritating to the skin. It's not good long term, okay? The non-rebreather is rarely used anymore, so I don't waste your time and mine talking about it, but I do want to talk about the most important mask of all. And Sister Girl over here has that mask on. And so this mask always has a bag. This is your non-rebreather, right guys? This has to be filled with air before you put it on your patient. Remember that. It's in there, it should be written, I thought. Yeah, it should be inflated, right? Don't write shit that's written, don't do dumb. Okay, you don't have time for that shit. Okay, so you put this on, but you gotta inflate it first. Now, I want you to think with your girl. This is where we put our thinking caps on. If I'm calling it the mask of choice for respiratory distress, and if I'm literally calling it a non-rebreather, then you have to think, well, how does it work? Get this. The patient breathes out, the flaps flap and let that air out. And what gas is in that air that she breathed out? CO2. CO2. If we're in true respiratory distress, would you agree the last thing my ass need is some more CO2? So once you breathe that CO2 out, when you inhale, these flap over the holes and close those holes so you don't re-breathe the CO2. Non-rebreather. So you're only going to get what? Oxygen. That's why it's for respiratory distress. That's why you go up to 15 liters anytime you call yourself pulling this motherfucker out. Act like you need it by putting it all the way up. Ain't no 4 liters with that. Ain't no 10 with that. No, pop that bitch up. Because you grabbed it, didn't you? That means your patient about to die without a little help here. So put it all the way up. Don't let me catch this on your patient on 6 liters. What the hell you doing? Wasting time up in here. She gonna be dead. Okay? That's how you do it, y'all. It's on the test. If you're gonna use a non-rebreather, it goes all the way up. Your Venturi mask is also called a Venti mask. This is for delivery of precise amounts of oxygen as only the COPD patient can need. So the little colorful little gadgets that attach to it, some of you may have seen the yellow and the pink and the orange and the green and the blue. That's the little gadgets, and they all deliver a different amount of oxygen. and they close off in certain ways to deliver that precise amount of oxygen. And it's always prescribed by Respiratory and the doctor, and that's a delivery thing. And we all used to know what that was, but now you have RT, you don't get to do the things we all used to do. But that is what that is. It's the Venturi mask, precise, really precise amount of oxygen delivered for the COPD patient. Okay, all right, now. I always like to give you some things just on a practicality standpoint. Do you see, if you go down a little bit where it says keep a sign on your front door? You do want to highlight that. You want to highlight that whole sentence, you know, all that kind of stuff. But let me just keep it straight with you, because if you down the way and you're doing home care, which I do a lot back in the day, your patient is not going to put that sign on that door. And the reason why the patient shouldn't really put the sign on the door, even though it's on the test, is because assholes that see that sign on the door are gonna know that that patient is really compromised, and they will rob that house or go in and kill her and do whatever they wanna do. So don't feel like, oh my God, we were told you gotta have a sign on the door. I need my nurses to be wise about the ways of the streets. And if you in the streets, you're not finna put that fucking sign on the door. Suburbia, go do you. But my people live down the way where I used to live, and we're not putting that fucking sign on the door, okay? So that's what you gotta know. Alrighty. Oh, last thing on that little oxygen list. Do you see where it says, remember, PaO2 is lower in the elderly? When you first came in here yesterday, we talked about pulse ox less than 90, PaO2 less than 60. Now let's make sure we remember our normals. What was a normal pulse ox? What is a normal PaO2?
60 to 80.
Listen to me. You must know the difference between abnormal and emergency. The emergency is the pulse ox less than 90, PaO2 less than 60. The abnormal is pulse ox less than 95, PaO2 less than 80. The elderly, their PaO2, as it says right on your sheet, is in the lowest part of normal. So these elderly patients, 65 and above, they're rolling out in the 80s normally, while you and I are rolling out in the hundreds. And so it's only when you understand that pathophysiology that you can understand why COVID killed so many. Because COVID directly worked on your PaO2. And so when we look at the elder people were the ones who suffered the most, it's because if you're starting out at 80 and you get COVID, it don't take you long to get below 60, which is death. And so your babies and your children did not suffer because they're here. Who else suffered? Well, anybody who had sugar. And what is sugar? Oh, the food for bacteria. Makes COVID very happy. It have a unlimited feeding source. All infection needs sugar to survive. So which patients died during COVID? Diabetics and obesity. Well, what does obesity have to do with sugar? Well, sugar is stored in fat cells. And so if you are obese, then COVID can eat off of you for days and never go anywhere and instead get worse. That's true for all infection, by the way. All right, so know your pathophys instead of being caught up in, you know, politics and that shit fake. This a conspiracy. The bitches brought that shit over from. Shut the fuck up. What is it? It's an infection. What kind? Respiratory. Who does it affect? Somebody with compromised respiratory effort in the first fucking place, and your elderly who already have a low PaO2. Science, not bullshit. All right? Okay, let's go. If you look at page 8. All enteral feedings are basic care and comfort. And so that's this one. In other words, your doctor ain't managing this shit. You are. You are. You're managing all the tube feedings, not the doctor. That's why it's basic care and comfort. Now, you guys blow this, so let's know this. If you look at the